Good day, my name is Bronwyn-Lee and today I will be presenting a patient case report on COVID-19 and fulminant myocarditis seen in a 39-year-old patient. Fulminant myocarditis is a syndrome that is uncommon, with a high mortality and various complications. It can be characterized by severe diffuse cardiac inflammation, which can often lead to death due to the shock of the heart, ventricular arrhythmias, and even multiple organ failure. Autoimmunity and infections are some of the multiple etiologies. However, a viral origin is the most common etiology along with multiple organisms. On the 11th of March 2020, the World Health Organization declared the severe acute respiratory syndrome coronavirus 2 a pandemic. The structure of the SARS-CoV-2 virus is described as a single-stranded RNA virus-enveloped virus. Its surface is covered by a large number of glycosylated S proteins, which helps it to bind to the ACE2 receptor found on the host cell. The virus has a rapid mutation rate of about 2 single-letter mutations per month. The infectious disease of the SARS-CoV-2 is known as COVID-19. A 39-year-old white South African female presented herself to the emergency room with no previous history of cardiovascular disease or any other chronic illnesses. The patient was not on any medication before arriving at the emergency room, and the patient's family had no previous history of cardiovascular disease. The patient had reported to staff that she had recently arrived from England, just 6 days before presenting herself to the emergency room. When the patient presented herself to the ER, her symptoms included palpitations for 3 days, which had suddenly started. This was associated with a feeling of general discomfort and uneasiness. The patient had no difficulty breathing or any chest pains and had no respiratory symptoms. A cardiovascular presentation was done on the patient upon arrival. This revealed that the patient was tachycardiac with a heart rate of 137 beats per minute. The normal range of heart rate should be between 60 and 100 beats per minute. However, the patient did not show any audible heart murmurs or an elevated jugular venous pressure. A respiratory examination was done which revealed bibasilar crackles, which is caused by excess fluid on both the lungs. When testing the patient's vital signs, the following was recorded. Blood pressure was 98/54, which is a bit lower than the normal 120/80. A 95% oxygen saturation, which is considered normal, and a body temperature of 36.5 degrees Celsius, which is still under the normal level of 37 degrees Celsius. There was also a cardiac index of 1.1. The following investigative tests were done on the patient. An electrocardiogram which showed a concave elevation of the ST segment, as well as a PR segment depression with a slightly downward sloping TP segment. This can be seen in Figure 1. A computed tomography scan of the chest showed that the lung parenchyma was compromised, and there were mixed opacities, mainly alveolar and ground glass of peripheral and basal predominance, as seen in Figure 2. This is a well-known pattern for the pulmonary involvement found in COVID-19. For this reason, nasopharyngeal and oropharyngeal swabs were taken, 14 viral and 4 bacterial. These were tested to identify the microorganisms causing an infection in the respiratory tract. The swabs came back negative. Therefore, a PCR test was done and was positive for SARS-CoV-2. Reticular interstitial opacities were seen in the initial chest X-rays, as seen in Figure 4. The patient was diagnosed with the following: fulminant myocarditis, Stage B cardiogenic shock, and COVID-19 pneumonia. The patient was treated in the intensive care unit. Treatments included oxygen therapy and a strong cycle of medication, which included the following: methylprednisolone at 200 mg per day, as well as intravenous human immunoglobulin 20 grams per day. These were given for a period of 4 days. Hydroxychloroquine was administered at 800 mg on the first day, and then 400 mg, along with 500 mg of azithromycin. Both were given for the duration of 5 days. Lopinavir was given at 4 tablets of 200 mg per day. This was administered for a period of 10 days. To give initial cardiac support, norepinephrine was used. Inotropic support was given with dobutamine for the treatment of cardiogenic shock, and levosimendan was given to increase cardiac contractility. Intravenous furosemide was given to help treat the edema and swelling in the heart. After 10 days in ICU, the patient showed sustained respiratory, hemodynamic, and clinical improvement. The patient's chest X-ray showed that the bilateral diffuse opacity cleared up after only 10 days of treatment. The patient was discharged from the hospital with heart failure management 16 days after her initial arrival in the emergency room. The patient's heart management included bisoprolol 5 mg per day for hypertension and high blood pressure, spironolactone 25 mg per day for cardiac failure, and enalpurol 10 mg twice a day for hypertension. There was consideration for the performance of a myocardial biopsy after the clinical improvements. However, the patient did not want to give consent to the procedure. 2 weeks later, a medical control was performed. The results had showed that the patient had no new symptoms, as well as a normal transthoracic echocardiography. The current understanding of fulminant myocarditis indicates 3 main factors contributing to its development. Fulminant myocarditis development due to autoimmune disease, fulminant myocarditis development due to drug toxicity. This can also be seen from treating diseases. Infection caused by various pathogens, especially viruses, which manifest in clinical features observed in fulminant myocarditis. Although uncommon, some viruses that usually infect non-cardiac organs, like human immunodeficiency viruses, HIV, for example, can also induce fulminant myocarditis. Patients who develop myocarditis often die of sudden cardiac arrest, arrhythmia, or severe heart failure soon after onset if they do not receive precutaneous cardiopulmonary support in time. The presence of fulminant myocarditis is rare. Few cases have been described since the beginning of the current pandemic. Myocarditis is when there is inflammation of the heart muscle. It affects the heart negatively by reducing the heart's ability to pump blood. It also affects the heart's electrical system and causes a rapid or abnormal heart rhythm. Fulminant myocarditis is the sudden onset of myocarditis due to autoimmunity or infections. Cytokines are cells in the body that are used to help the body fight off infections as a natural immune system response. Too many cytokines, however, can be very dangerous and is commonly known as a cytokine storm. A cytokine storm signals to the body to start attacking its own cells and tissues instead of fighting off the actual virus itself. Cytokine storms bring about inflammation to the heart. When the body tries to defend itself against COVID-19, for example, In some cases, it brings about a cytokine storm, which can then cause inflammation in the heart. This then leads to fulminant myocarditis. The sudden onset of this myocarditis can be extremely dangerous and even deadly to patients. The progressive nature of the disease is characterized by severe and sudden onset, which is marked by a rapid deterioration within 2 weeks that can occur within 2 or 3 days. The disease does not only affect the heart and is known to affect numerous organs. One of the main organs affected by fulminant myocarditis is the lungs. The inflammation in the heart affects its ability to pump blood effectively from the lungs to the rest of the body. This causes a pressure buildup in the veins inside of the lungs, which then causes fluid to be pushed into the air sacs in the lungs. The more liquid that builds up, the harder it is for the patient to breathe. Inflammation on the heart can also lead to liver damage, if not treated urgently. Since the liver receives up to 25% of the cardiac output, varying ranges of cardiac output due to myocarditis could drastically affect the liver. Although fulminant myocarditis does not affect the bladder directly, the medication used to treat the myocarditis can cause bladder and bowel issues, such as a sudden and urgent need to pass urine. Fulminant myocarditis may lead to the heart not pumping blood correctly. This could lead to pressure buildup in the main vein that is connected to the kidney. This could then cause a blockage in that vein, which would lead to a reduced supply of oxygen to the kidney and in turn lead to kidney disease. Clinical diagnosis for fulminant myocarditis were predominant symptoms such as fatigue, cough, dyspnea, and chest pains, which often show no distinguishable differences from the common cold. An important feature of fulminant myocarditis is its rapid clinical progress, which can quickly lead to hemodynamic dysfunction and circulation instability. This is presented as a sharp drop of blood pressure. When the patient presented to the ER, her symptoms were heart palpitations and hemodynamic instabilities, which are consistent signs of myocarditis. When a suspected patient is administered, routine tests including physical examinations, blood chemistry, 12-lead electrocardiogram, and emergency echocardiography should be conducted. Physical exams may reveal signs of heart failure, including decreased blood pressure, accelerated heartbeat, and marked decreased heart sounds. Routine blood tests may reveal elevated neutrophils or lymphocytes, indicating the presence of infection. Viral serology assays should be conducted, but importantly, negative results do not necessarily rule out positive viral infections. ECG tracing should demonstrate arrhythmias or tachycardia. In the case of the patient, although she was negative for bacterial and viral infections, she did test positive for SARS-CoV-2. A patient was described with the following: a sudden onset of palpitations, the patient's ECG which showed an ST segment concave elevation and PR segment depression. These are compatible with acute myopericarditis. The echocardiogram showed a systolic dysfunction. The MRI showed an inflammatory process which aided in the diagnosis of fulminant myocarditis. Since the beginning of the pandemic, there have been very few cases of fulminant myocarditis. The increased biomarkers could be related to about 8 to 12% of acute myocarditis cases. The possible cause is thought to be due to injury to the myocardium by a cytokine storm, which is triggered by the virus and is related to the severe inflammation. This suggests that the inflammatory response is due to SARS-CoV-2, which originally takes place in the lower respiratory tract, as seen on the patient's chest X-ray. In the hypothesis, it is said that the combination of hydroxychloroquine and azithromycin results in a viral clearance. However, we only administered these drugs on day 7 of the patient's treatment. Lopinavir was also administered, as their use led to a shorter stay in ICU. Due to possible myocardial damage and adverse events that were not yet observed, dosages for the medications were controlled daily. Emphasis should be drawn to the fact that there is a lack of clinical trials on cases of fulminant myocarditis due to COVID-19 and how it should be treated, especially with the new strand that is more vicious than the last. Fulminant myocarditis is rather rare. However, with the numbers of people infected by COVID-19 increasing, it is important for a clinical technologist to ensure that they do not miss the signs seen that relate to COVID-19 and the possible secondary outcome it may have on the patient, such as fulminant myocarditis. Fulminant myocarditis is a rare complication that requires clinical suspicion for early diagnosis by means of ECG, echo, chest X-ray, cardiac MRI, and other tests that may help the diagnosis. If not caught early enough, fulminant myocarditis could be fatal for a patient. Cardiology clinical technologists therefore play a very important role in the diagnosis of this disease by doing the required testing to the best of their abilities. Thank you for your time today.